Continue. There we go. So, hi everybody. Nice to be joining you all here. This is pretty exciting that we're getting to this, even if it's virtual the first time around. So I wanted to, today jump right in because I had a really hard time cutting this down to 20 minutes because I have a lot to say about shoulders. So we'll kind of jump right in and we'll dive deep and then come back out and we'll kind of see and round out with lots of questions, hopefully, if I save you guys time. Okay. So yes, we'll talk about shoulder pain following spinal cord injuries, and that's working. So I've got to just minimize my Zoom part so I can see my notes. Okay, so shoulder joint pain is one of the most frequent secondary complaints of people following spinal cord injury, with a prevalence ranging from about 1/3 to 3/4 of the population, depending on the studies. So prevalence increases with the level of injury and with the time since injury. And it's important to note as well that it's twice as common in females. No, I'm not advancing. There we go. So transfers, wheelchair use, pressure relief, gait aids, and repeated overhead activities all contribute to the repetitive biomechanical loads on the shoulder following a spinal cord injury. So depending on the level and type of spinal cord injury, these demands may be put on a neurologically intact shoulder if the level of injury is kind of mid-thoracic to lower thoracic, or not neurologically impaired shoulder. Now it seems obvious, but it's also worth stating, although not the focus of my presentation today, that when considering any task or environment that may contribute to shoulder pain, if something can be done to change the task and change the environment, get more equipment to lessen the load on the shoulder, that should be the first thing. Today's focus, however, is the influence of the neuromuscular deficits and the muscle imbalances on the susceptibility to shoulder injury. So important to kind of take a step back almost. I think sometimes we think shoulder, we go right to glenohumeral, we go right to treatment. And I want to take a step back because I think if we kind of rethink our assessment and go a little deeper into the shoulder, we'll rethink our treatment and do a better job. So the shoulder complex is much more than a ball and socket joint, right? It consists of the sternoclavicular joint, a acromioclavicular joint, glenohumeral joint, that's where we do think the shoulder, and the scapulothoracic joint. Now, even though that's not a bony joint, very, very important, spend lots of time on it, so I added in. Now, the glenohumeral joint is a floating joint, so with minimal structural stability in its joint shape or from its ligaments, and so it requires more dynamic stability and neuromuscular control. Now, the cervical and thoracic spinal movements are integral to the shoulder. In order to have proper shoulder movement, you have to have, good spine movement as well, if possible. And the shoulder is the primary stabilizer of all the upper extremity movement. So if we're looking at like liftoff or transfers, a closed chain, that stability for all the power coming from the arm has to be anchored in the shoulder. Or for open chain, when we're reaching out of the base of support, that all comes from the shoulder. So, movements of the scapula. I use the term floating joint because the socket, although very shallow, is part of the scapula. And the scapula moves in many, many directions. So I'm going to get you guys to put up your hands, if you can still see my video, palms away from you, okay? And then, so the planes of movement. If you think of your hands like the scapula on the back of someone who might be sitting in front of you, if we're just like you're washing a window, kind of wax on, wax off, the scapula can move up and down. So it can elevate, it can be depressed, that's all in one plane. It can move in, which would be retraction or adduction, and it can move out, which is protraction or abduction. It can also internally rotate, so that would be like you're waving, like the royal wave, okay, like your palms are coming together, or externally rotate. And it can anteriorly tip, so that would be like your fingertips going down, and posteriorly tip. So it sits, the scapula sits with the base of the spine of the scapula should be about T3, and it should be sitting roughly parallel. This medial border should be roughly parallel, maybe slightly upwardly rotated to the spine of the spinous process. And it's sitting in about 10 degrees of anterior tipping and about 30 degrees of internal rotation in its resting point. Now, if it's not sitting in this resting point, if it's already too anteriorly tipped, if it's already too protracted, we're going to have difficulties down the road when we look at the shoulder movements. So I just want to review all this because ultimately everything kind of comes from where the socket comes from. So we have to understand the movement of the socket on its own. Okay, so back to the ball and socket. Lots of movements, right? This long list of movements: flexion, extension, abduction, adduction, internal, external, horizontal movements, circumduction. All of these don't just happen at the humerus and the glenoid, right? So there's a combination. So the picture shown here is the most common kind of demonstration is abduction. So if we're thinking about normal shoulder abduction, it's 180 degrees, but it's a combined movement of the scapula going 60 degrees into upward rotation, and the humerus and the glenoid fossa going the other 120. But in order for that to happen, correctly, you need to have some thoracic extension, sternoclavicular joint posterior rotation, and some scapular posterior tipping and anterior rotation, internal rotation. So that's why we don't just want to look at one thing. I think all the other things that are happening, even it's not just scapular or upward rotation and humeral head movement. So like, for instance, if we're thinking about, we want to see normal upward rotation, we need to have upward rotation without winging of the inferior angle. So although we kind of think of our rhomboids and our inferior traps as kind of adductors, right, or downward rotators, they need to eccentrically control the scapula as it upwardly rotates. And if it doesn't, even though they're not your key muscles for this movement, if they're not stabilizing, we're not going to have normal movement. So that's kind of the deep dive into it that you can get kind of overthought, but it's like, whoa, every movement, there's a ton going on. And if we don't understand, if we just say, oh, they're missing abduction, we need to work on that. You got to make sure you're working on the right thing. Okay. Arthrokinematics, another little deep dive I got it deep into. So arthrokinematics are the way the joint surfaces interact. In this case, the convex humeral head moves within the concave glenoid fossa. So if you can still see me, make a little cup, ball. If as we're doing abduction, the humeral head has to swing up. If it just rolled right out of the joint, wouldn't be very good. So as it rolls superior, it's rolling up, it has to slide inferior to remain centered. Seems like a small thing, but it's so important that this is working properly. It preserves the action of the arthrokinematics. Well, I've got a picture didn't show up there. The action of the arthrokinematics preserves the length tension relationship of the glenohumeral muscles. It prevents impingement between the humerus and the acromion. So you see in the second picture, when it doesn't slide or glide down, we get the bursa getting pinched, we get the supraspinatus being pinched. There's certainly a lot of other vessels going through that subacromial space and nerves that could get pinched. So if that doesn't slide, we're having a lot of lack of integrity in the non-contractile elements of the joints and a lot of impingement. All right, so deep dive without going within a very short presentation into kind of shoulder thoughts. Lots to think about. Every movement of the shoulder, you could reassess what's happening in the arthrokinematics. You could assess what's happening in the clavicle. You want to really break it down. And I wanted to just do a quick but deep dive to remind us that there's a lot more going on before we get into how to assess. Okay, so with shoulder assessments, they start with a really good subjective history. The majority of the time, I can narrow down my differential diagnosis in a good subjective history. So where is it hurting? Where is it radiating? What type of pain are you having? What brings it on? What makes it better or worse? What are you having difficulty with? What's your occupation? What are your hobbies? What do you like to do? Okay, are they right-handed, left-handed? What position do you sleep in? All of that before starting the physical assessment. Now, this is, I come to this neuro world with kind of looking at the shoulder from a bit more of an orthopedic perspective. But of course, it's really important to consider your expectations are going to be different depending on your patient, what their level or type of injury they have, and whether or not they have neurological impairment to that shoulder or a component of the shoulder or the stabilizers or not. So specifically and especially the strength testing expectations will vary greatly depending on the level and type of spinal cord injury. Okay, so starting off after we've got our subjective, we're going into an observation. So looking at their resting posture, And this, I should say, this starts as soon as you see them, not just when they think you're looking at them and they sit up a little taller, as we all do when everyone comments on posture. It's when they're sitting, waiting to come see you. It's as they're reading a book, when they're chatting on their phone, all those kind of things, when you're going to get a lot of information. Now, once the formal assessment starts, you get so much more information if they're comfortable and you're able to get them to remove their shirt. Like, we really should be doing this more. It's pretty hard. We don't want to just look, do they have full range? We're looking at the quality and where the movement's coming from. You need to be able to see that. So again, looking at the posture, their cervical posture, thoracic posture, position of the scapula, and be really specific. It's easy to say, and we all, unfortunately, get into this habit of just saying like protracted, rounded, chin poke, and that's very vague. It's not good enough as clinicians just be saying that. We need to be more specific. So for instance, here's what I see a lot in kind of my SCI population. So if you are seeing protraction of the scapula, and that usually comes with increased anterior tipping, you're going to expect to have a weak mid and lower traps and maybe a tight pec. So I'm going to comment specifically on the different parts of the scapula and the humerus. So if there's a prominent inferior angle or medial border, it's indicative of labral tears or capsular stress, and that's what would lead to an arthritic change. If the superior medial border, where it kind of pops out near the spine of the scapula, is popping out, that's more indicative of impingement type syndromes and rotator cuff strains. The angle of the arm with respect to the humeral head, also an impingement type thing, or a bicipital kind of irritation if you're being pulled that far anterior. So commenting on all these things, and at this point we're just putting it all together to see what's going on, how they're overusing. Might comment on their muscle bulk or muscle wasting, if they're overusing or underusing certain muscles. Muscle length. It's kind of a funny one for observation, but you can see in the top left picture, this guy has a really long upper traps, like that slope of the shoulder versus a really tight, short neck. Those kind of comments are all going to change how they use. And of course, when you're observing them, if they're coming saying, this is what's hurting, obviously, so watch them transfer, watch them, on their phone, lifting up. If they've got a little one at home on the ground and they're sitting in a wheelchair, lifting up, you want to watch what's happening, or at least get them to kind of mimic it so that you can really see what's going on. Okay, active range of motion, still very observational, but it's through movement. Asking them to reach over their head, maybe not specifying flexion or abduction, just see what comes naturally as they reach. Tell them to scratch their back, and then you can get more specific if you're not sure what's going on, because when you just say reach, you might be not sure what you're seeing, but when you specifically say stay in this plane and do abduction, you might be able to get more information. So we're looking for a pattern of restriction, so you can, this is going, farther in, but there's a capsular pattern of restriction versus an external rotator cuff pattern of restriction or pain. So you can get a lot of information about being like, oh, they have no issue with flexion, but really when they come into any external rotation, they can't sustain that. Something's catching there. That's going to give you some information. And this is also the motor control, right? We're not just really, do they do it, but how they do it, how they get there. Not recruiting certain muscles, over recruiting other muscles. They're looking at the scapular movement and where there might be pain. Remember, active range of motion, we're all looking at a shoulder, you're always going to look at their neck and their thoracic spine. Okay, strength testing is not just manual muscle testing. That's not good enough for this area of the body, and isometric doesn't cut it either. We need to be testing through range. Remember, this is what I talked about a few minutes ago about, remember the expectations might be different depending on your patient. You still want to get a very, very thorough, even if you say you don't anticipate they're going to have very much movement there, you're going to ask them to do it and see if they're compensating with something else. You're going to see what's causing them to say abduct. Now, I was expecting this, but I'm seeing something else. And remember, we're not just looking at the glenohumeral joint. You need to assess the stabilizer muscles as well. So you should be testing the rhomboids, testing inferior traps, serratus anteriors, subscapularis, all those stabilizer muscles too. And again, looking at sustained and fatigable in a neuropopulation. This isn't just, is it happening? It's how it's happening and the quality of it in a repeated action as well. Okay, passively, it's kind of relative to the active, right? If they had a great abduction, but they might be compensating for the fact that their lats are pulling them down. And when you take them into it, you're like, wow, they're really fighting some tightness. They're not that weak. They're just really fighting something. Or maybe it's like when you get to that end field, you're like, oh, it's capsular, right? Like, is it that they're really tight, or is it that like that capsule is really constricted? Is this like a capsulitis type issue? So feeling is there tone and spasticity? So you want to vary your speed that you're assessing the passive range at. You're going to look at the length of their nerve, like doing nerve glides and nerve testing. And you're going to do the arthrokinematics, so finding out how that ball actually moves in the socket, as well as palpation. Now, again, sometimes we know about the shoulder and then we go to assessment and we forget about everything except the glenohumeral joint. So all of these things should be happening even at the sternoclavicular joint, AC joint, scapulothoracic joint, right? It's not just glenohumeral. Okay, this is where I want to turn, and I think, you know, the title was, what are common injuries, right? That was what I was asked to speak on. And I thought there are a lot of common injuries, and I could just talk about the injuries specifically, but well, I'll get to why I think that I've changed the way I did this talk. So remember how I said that by listening to a really good subjective history, I could narrow my diagnosis down. You add in a little bit of strength testing, maybe a few special tests, a bit of palpation, and bingo. I probably have a diagnosis, and I might even have the right diagnosis, probably do. But I think if that's what we do, we're kind of missing the proverbial forest for the trees. So let's look at an example. So this list that's up there now, these are the most common, from the research, these are the most common shoulder injuries specific to SCI population. Now, it's not in any order because depending on who you look at, it's very inconsistent and weak evidence on that. So it's a bit of a like amalgamation, but it is the most common. So if I was to pretty easily, if I feel some warmth over where I'm expecting to palpate, it's tender to touch, I've got some positive impingement testing, but isometrically the patient is strong, I'm pretty sure I could say there's some sort of a bursa could be irritated. I might have indications for rest, ice, knowing it's a bursa, it's one of the areas where ultrasound might be helpful. So, or if I had a positive Yargans test, I could jump right to bicipital tendinosis. So here's the thing, that you can get a diagnosis pretty fast and think, but I didn't have to go into depth about all that other stuff we did. So yes, acutely, a bursa or a rotator cuff injury or a biceps tendinosis and a nerve impingement will have different treatment strategies. I'm not trying to say we're going to treat them all the same, but if that's all we're looking at, and that's once we get a diagnosis, I'm just thinking about treating nerve because I know it's a nerve impingement, I'm not treating the whole shoulder, then I'm kind of just treating the symptom. It's a bit of a Band-Aid solution. So it wouldn't be a wrong diagnosis. These are all accurate. And the treatment plan would end up decreasing the pain and assist in healing in the acute phase. But the real question of why did they get this injury and how can we prevent it from happening is way bigger. And the same thing applies when we get a diagnosis from the diagnostic imaging. So it actually tells me very little of what's really going on. It just tells me the tissue that might be causing the pain. Now, I know some of you thought I'd go condition by condition and what tips to treat, but I wanted to take that step back and look at the pattern of what's happening. The majority of spinal cord injury, shoulder injuries are repetitive type injuries caused by faulty movement strategies. So I want to urge you not just to diagnose the tissue causing the pain, but rather the movement strategy that is faulty, because that's what's going to drive the treatment. And I know I'm coming at this from a physiotherapist perspective, but I want us all to kind of think bigger when it comes to the shoulder. I've got a tiny bit of time. I'm going to go probably faster than I should, but I think it's worth going through anyways. And so at least you have some idea of talking about treatment. So the goal is to restore as close to typical movement patterns as you can. Consider the limitation. We need to prioritize our impairments, right? We've got to choose what we're going to target first. So if there is a passive restriction from the joint, a muscle, or tone, we need to usually target that first and work into weakness. Don't wait till you have fully great range to work on strength, but you've got to choose. And if the issue is neither of those things and we have poor motor control, but everything, then that should be the focus. I do a fair amount of manual therapy because that's kind of my background before I moved into a neuro population. And I find manual therapy really helpful in helping me with my diagnosis. So in this way, you're hands-on, this is more passive treatment. It can be very effective. It can never stand alone in your treatment. So all these things can help. I won't go into detail about all of them, but any of these things can really help. And I find manual therapy is often a check if I'm on the right pattern. So I think that you don't have enough posterior glide with your flexion. I can do some joint mobilizations, retest, and I can probably tell if I'm on the right track for getting to the right solution. Exercise, I would love to do a whole presentation on exercise, but again, when I think about the shoulder, I still want every conversation when someone comes to me in my clinical practice and says, hey Mary, I've got this good shoulder, and we jump right to, oh, how to teach scapular retraction. It's like they don't even know what's wrong with the shoulder, so why are we jumping right to retraction? And honestly, it's the most overused exercise. That's another topic. But tissues change with movement and positioning. You need flexibility in all tissues. Scapular movement, this is a through movement. So it's not just retraction. People think, I need to stabilize my shoulder, then I can move. You need to have appropriate stabilization of the scapula while you're moving the arm. The scapula is not supposed to be attached to the thorax indefinitely. Some of my favorite therapeutic exercises, I have put in a few of them here. I'll do one with you guys because we have 2 minutes. We've all been sitting too long. You're probably all sitting. If you put your hands kind of on your desk or in front of you, it's called threading the needle. If you take one arm, put it through and then up, reaching to the ceiling, is my favorite scapular extension and rotation exercise because it's a really functional combination of movements with reaching using the whole chain, and it usually feels great if you want to do a few of those. Everything you do, like I said, it all depends. There's no good exercise. There's only the right exercise for the right patient. So, I mean, as long as you're facilitating the exercise correctly, that's what matters more. You've got to narrow it down to just a couple exercises. People don't do full program. That's not what we're aiming for. We've got to give them a few things they're going to do frequently. And also remembering that the exercise could just be how you change their pattern. So transferring is a big one I give people. When every time you do a transfer, I want you to reconsider where you put your hands. Maybe you're a little more externally rotated through your hands. And I want to consider how much you shrug or shift or retract. And I give them lots of feedback. And you're going to do some real setting and just loading the shoulders in that position before you go to transfer. So consciously making those changes as part of their functional movement so that they're going to make the changes more permanently. Quick note on taping bracing, only because I do still use it and I think it's important. Great for proprioceptive feedback and support, especially if you're working with someone who may not have the glenohumeral anchoring. So if they need some support in there, not a true subluxation necessarily, although taping can be useful for that as well. And ultimately, the most important thing we do is educate. I think everyone needs to know more about the shoulder, so we need to educate ourselves, and so we can educate our patients. I consider, anyone who's going to be using their arm, might be in a wheelchair or using gait aids. These are now athletes in weight bearing and or overhead activities equivalent to a swimmer or a volleyball player. We should be looking at all their shoulders, focusing on prevention, their techniques, being really picky about the foundation when we first are teaching techniques, and helping them to stay fit, because prevention is really, really key here. And I'd just be remiss, it's not my area to of course mention that this doesn't stand alone, conservative management. You may need medical. The majority of spinal cord injury who have shoulder issues will be on medical management, so you've got to work with them. A lot of times it's to do with the spasticity, and so you're playing around potentially with the physiatrist about that medication. So this is not a standalone thing. And I know we did a ton today, but if you got something out of this, What I want, hopefully, is to remember to consider the whole shoulder complex, not just the glenohumeral joint. We need to get better at assessing shoulders holistically to identify the patterns that cause the overuse problems and prevent them. The majority of spinal cord injuries are repetitive type injuries caused by faulty movement strategies. I urge you, don't just diagnose the tissue causing the pain, but rather the movement strategy that's faulty, because that inherently is the solution. And be really specific with your treatment and exercise strategies, because you can't give too much. You've got to be picky. And ultimately keep moving, because we also know that just general fitness helps in both pain and shoulder health. All right, I made it through.
Thanks, Mary. That was awesome. I do have a question. Have you noticed shoulder tendon ligament issues with SCI patients who have been taking certain types of antibiotics, i.e. Cipro?
Ooh, very good question. And I'm probably not qualified. I can speak from my opinion, I suppose. Not that the Cipro, not that an antibiotic has specifically affected their injury. I work currently in acute care. I have worked in tertiary as well, but I haven't noticed that correlation. Reviewing some of the research, getting prepared for this, I think like I'm going to jot that one down, like some medical things. I always do this, that I end up with more research questions than I have answers to. So no good answer. No, I haven't noticed that myself. I don't know if anyone on the call is able, we could pause at the break if anyone wants to speak to that. That's interesting.
There's another good question. I'll get to that one in just a second, because Andrew actually put a good answer about it in the chat box as well. But Rebecca's asking, do you have a top 3 recommendations for shoulder preservation after spinal cord injury, i.e. what could a person do in the acute phase to try and limit shoulder pain / injury years later?
Sorry, I was confused if I was still sharing my screen and I got distracted for a second.
You want that one again?
Yeah, can you?
Yeah, no worries. Top 3 recommendations for shoulder preservation after spinal cord injury, i.e. what could a person do in the acute phase to try and limit shoulder pain / injury years later?
Yeah, in the acute phase, it's a lot in your medical team. Depending on what your presentation was, like if this is a traumatic thing and you're spending time in ICU or very long in acute care with any other injuries, the positioning is really key. It would be for whether you're neurologically impaired or otherwise, but spending the time in various positions, because as soon as you're spending time bedbound, it's pretty hard. As a clinician, but also as a patient, it's being really, really picky. It is so much harder to unlearn a technique than to learn it properly the first time. So being really, really picky, wanting your patients to have success, but being super, super picky about why they're doing things a certain way. I akin it to like when I'm teaching gait progression. There's a certain point where I'm like, I know we're working on it in therapy, but you shouldn't be working on this on the unit or yet with just nurses, because unless it's facilitated properly, you're going to get a lot of bad habits. The exact same thing is true with transfers and loading the shoulders.
Okay, I've got another slightly bigger question, and I'll give you Andrew's response as well. But before we get to that one, Dr. Charbonneau did say Cipro and other related antibiotics called fluoroquinolones can certainly cause tendonitis and tendon rupture. Excuse my pronunciation if that was awful. So there's an answer there. And then we're going to go back a little bit. So this is the big question. Do all physios in Alberta have the same knowledge? More specifically, the professionals who order wheelchairs. How do people living in rural communities access physios who are well-versed in neurophysio? And before you answer that one, do you want me to say Andrew's question and then maybe you can add on to that?
Sure.
So Andrew replied, sorry to jump in, but unfortunately your question doesn't have a great answer. Wheelchair advice is specialized, and the baseline knowledge expectation from a PT perspective is very basic on graduation. There is work being done to try and increase the knowledge base like this conference, but there's still a gap, especially for rural areas, and may not even have a regular therapist. Andrew has a question after that, but if you have anything to add, go ahead.
Sure. Yeah, I mean, like this at conference is a great example of how it does vary. I think we all come at it from different perspectives. I mean, you could say that for any physio, like just as with what we do. If you went to any physio with a back injury or a tennis elbow across the province, you're going to end up getting slightly different treatment. And that's not even to say that one is necessarily better than the other, because there are different good strategies. But I think in this population, there probably needs to be more consistency. But that's me speaking from a personal perspective.
And Andrew's also asking, do you think there is a reason why traditional neuro PT tends to not consider orthopedic evidence for treatment techniques?
That's a good one. I think it's not that they're not considering the evidence. I would say it's not like that. It's just that our brains, when you go into neuro, you're often we're grouped more with stroke and brain injury and the neurological impairment side of things. So we're thinking about the innervation, and we just focus more on that. We're also really big on function, which is great and it's awesome. And I think maybe the ortho world needs more of that. But I think it's more just who we surround ourselves with. It's who you're around, and so that's what you get. And coming from an orthopedic side of things, when I entered the neuro world, it's been interesting to pick and choose, because I also have learned a lot that I may take back to an ortho patient as well. So,
and then one more: it just jumped around. Can certain sleep patterns and position increase shoulder pain? And what recommendations regarding sleep habits can decrease pain, especially for SCI injuries?
Yeah, definitely. Sleeping is actually really, really big for shoulders. And conversely, the opposite is actually like shoulder injuries compared to any other orthopedic injury. And I'm going to bastardize the exact study because I'm speaking offhand, but impacts for sleep more than any other orthopedic injury is shoulders, for some reason, really, really correlated to poor sleep. And that makes me think of the sleep position hugely. If you were a side sleeper, like you can imagine the position of your scapula, if you kind of like collapse, especially if you're a hypermobile or largely mobile person, if you're up and twisted, if you're on your side, if the way you offload is rolling onto your shoulder instead of rolling over your shoulder, it can really make a big difference. The best is knowing a neutral position. And the truth is, like, we all just need to get good sleep. Sleep is magic. So if you can find a way to get good sleep, try and use pillows and positions to try and make sure you're in as close to a neutral position as possible. For the shoulder, back sleeping is the best, typically, and putting your shoulder in what's called like an open pack position. So the most neutral joint alignment is about 30 degrees of flexion, 30 degrees of abduction, and a tiny bit of internal rotation, which is a fairly natural, like, pillow on your tummy resting position, typically is a good go-to. Yeah, but don't have the shoulder under your, don't have the pillow. This is a pet peeve. The nurses put the pillow underneath your shoulder and then they're pulling you into protraction. So that the pillow should be under your elbow and your forearm, not underneath the shoulder. Otherwise, you're kind of defeating the purpose. Yeah.
That's awesome. Thanks, Mary. Yeah. That was all the questions in the chat box.
Great.
Thank you.
Thanks.